and we'll get going. So, as mentioned, we're excited to be here to be talking with you about using dissemination and implementation science to accelerate innovation. Okay. We have no conflicts of interest to share. Our key learning objectives are describing key principles of D&I science and their relevance to improving innovation and health, describe common frameworks and strategies used in D&I science to accelerate adoption of evidence-based practices, and applying an implementation strategy to address a practice gap. As mentioned, we'll be kind of going through what is D&I science, talking about the ICTR D&I Launchpad and what kind of resources we have, and then Dr. Ellis will give some application. There will be time at the end for discussion and questions. If you have questions while we're talking, feel free to put it in chat. I will fully own that I might not see it. So if I don't see it, and it's an important clarifying question, please come off mute. Otherwise, we will address it at the end. You can skip through the bios because you did a wonderful job sharing about who we are. So I'll kind of get started with, like, why do we do dissemination and implementation science? So what we know across several major areas of care is we actually have very strong evidence and very clear guidelines, but we see really big gaps in what actually happens. So for example, in hypertension, there are 11 National Professional Society guidelines telling us exactly how to manage it, yet less than half of patients nationwide have their blood pressure controlled. We see the same pattern in oncology. All NCCN guidelines recommend referring eligible patients to clinical trials, but only 8% of cancer patients ever enroll into a trial. And even though multiple NCCN guidelines call for genomic testing across cancer types, only 20 to 71% of eligible patients actually receive the recommended test. So the issue isn't actually lack of evidence or not having the tools. The issue is implementing the evidence consistently. So this is where implementation science can come in and help us. It can help us understand the barriers, it can help us design practical solutions and close these quality gaps so that patients and other partners can truly benefit from what we already know. So what is the kind of world of D&I science? What is this maze I'm talking about? First things first, I'd like to level set by defining what we're talking about. The thing about talking about dissemination and implementation is often we hear these words often. And so we kind of think we know what they are, but we're talking about them in very specific ways. So first, dissemination is a targeted distribution of information or intervention materials to a specific audience. And audiences are broad and can be defined based on a specific project or context, but it's targeted distribution of that information. Implementation are the strategies to adopt and integrate evidence-based integrations within the specific settings and context. So not just doing the thing, it's how we do it and adopt it and integrate it. And finally, D&I research is the goal of D&I research is to increase our understanding of how to get those evidence-based programs, practices into place. So how do we actually do them into practice in real-world settings? So what's all this fuss? Why are we keep talking about D&I science? Well, as I keep coming back to, many evidence-based healthcare interventions fail to produce successful outcomes when actually implemented into practice. To improve health, it is essential to not just understand how to create and do the interventions, but how to ensure that they're effectively delivered in practice. So a fun saying that Shellie often says, the healthcare intervention that is 100% efficacious, but never used is 0% effective. A previous director colleague always gave an example of bed alarms for falls. So back in the early mid-2000s, bed alarms in hospitals were a very common practice to try to reduce falls among older adults or folks with disabilities in the hospital settings. But the effects of them were not great, even though in theory, if they should be 100% efficacious, when actually used in real world practice, the falls rate was not declining. And when investigated, it found that there was a lot of alarm fatigue for staff and a disruption for patients. So they were just turning off the bed alarms. So even though this was a well-designed, efficacious intervention, when never used, it was 0% effective in reducing those falls. And we see this happen again and again with some really effective healthcare interventions just not being used in practice. So most of the questions we kind of do know what to do. It's how do we actually get it done? So this is all to say the evidence to practice gap is quite large. It is often referenced that on average, it can take 17 years for research to be adopted into routine care. And then even then, only 14% of that evidence ever reaches patients, so leaky pipeline problem. And also 18% of providers say they only consistently use evidence-based guidelines, which means over 80% of them are not consistently using evidence-based guidelines in their practices. So these numbers show how much opportunity we have to close the gap between what we know and what we are actually doing in healthcare, and D&I science aims to do that. So implementation science is a relatively new field. So if you can see kind of by publications, it's less than 35 years old. Now it builds on a history that has gone on much longer than that, but implementation science as a specific field is still considered relatively new. But it is maturing. I mean, it's probably now in the kind of gaining momentum. They're solidified into a field of science with dedicated journals, training opportunities, funding mechanisms. It's solidly a young adult in terms of its lifespan of a science. So there's lots of opportunities now for D&I, and we are seeing it across the board and bought in for its importance. I think, though, at its core, and to note, is that D&I builds on other disciplines. It is fundamentally social and behavioral science, and it leverages the many relevant streams of knowledge, and we can build upon this prior knowledge rather than kind of rediscovering what is already known. So we're not necessarily trying to rebuild the wheel as much as building on what is already known in some other disciplines. So really, it's important to acknowledge those foundations of what implementation science is already building on, but does not diminish the value as a new field. So, for example, in a single project, one might use many of the social sciences. So, for example, survey research and qualitative methods to diagnose implementation barriers and figure out adaptations to the intervention. And then one might use econometric methods to figure out the primary effectiveness outcome of our intervention. So really, it's a multidisciplinary set of theories and methods that build on each other to try to expedite translating research evidence to everyday health-related practices. So D&I, big umbrella, it spans the whole journey from innovation to scale. It includes engaging the stakeholders and other partners who are interested in the intervention, in the product, in the guideline, understanding end user needs, identifying barriers, and spotting the quality gaps. We often use hybrid designs to study the kind of both these things together, to study effectiveness and implementation at the same time, so we can assess the key determinants, the different contextual factors, and map them to the right strategies, and then finally to test them to make sure that the evidence actually takes hold in the real world practice. So it's a whole life cycle of a product and project. Where D&I is answering these questions. How do we shorten the time it takes for research to reach real world practice? How do we increase the success of dissemination, implementation, and long-term sustainability? And ultimately, how do we bridge the gap between what we know and what we do in the real world settings? Those are the core missions of D&I. I want to give a couple of examples about how we know implementation science works. And Randy Brown in his introduction gave a nice little side into that. He's worked with implementation scientists over the years. As you will see, it's with other colleagues in Department of Family Medicine and Community Health, a dear friend and colleague of ours, Andy Quanbeck. They have been working for years on different trials to test different implementation science strategies. So one particular one that shows kind of how it works was this impact of a digital medicine support for alcohol use disorder. And Andy is a wonderful expert in D&I science, and I encourage you to, work with us, but also consult with Andy because he's just a wealth of information related to how to integrate implementation science into your work and research and how to optimize its use. And what they found in this is with the hybrid effectiveness trial that there were different support models that they could use. So a self-monitored approach, a peer-supported approach, and a clinically integrated embedded in workflows approach. They use different implementation science principles about adaptation to the clinical context, partner engagement for feasibility, and then measured outcomes of both effectiveness and implementation metrics. What they found is that it reduced heavy drinking days using these different support models from 38.4% to 22.5%. That's a super brief overview. Please ask your colleagues for more details. Another example from your colleagues was in clinical implementation of an AI-based screening for risk for opioid use disorders in hospital adults. Again, many of your colleagues were on this project, and it was the design of a BPA that was hoping to kind of address this evidence to practice gap that shows early identification in addiction medicine consults can improve outcomes, yet routine opioid use disorder screenings are rarely implemented in hospital workflows. So we used an implementation science approach where interviews were conducted with advanced practice providers, residents, and attending physicians from different inpatient units to identify potential barriers to using the AI screener. We utilized different implementation science theories and methods to try to create strategies to address those barriers, and then used a pre-post evaluation to assess the real-world effectiveness. And what was found is that it did reduce the 30-day readmission rate. So the AI screener achieved similar consult rates to usual care and reduced the 30-day readmissions, which demonstrated a kind of scalable, cost-effective intervention for the health systems. And then finally, another example that has some impact for family medicine is one done by colleagues, Christy Bartle, who's in rheumatology, but also a past family medicine colleague at UW, which was connecting rheumatology patients to primary care for high blood pressure. And what is seen in the evidence is that the systematic blood pressure follow-up reduces cardiovascular events, but specialty clinics lack the structured protocols to connect patients to primary care. And so they adapted an evidence-based protocol for the rheumatology setting using several different implementation strategies and addressing barriers to implementing this protocol. And what they found is that by doing this, they had timely follow-up. It's more than doubled. The median time to care dropped by 33 days, and high blood pressure at rheumatology visits fell from 17% to 8% over 24 months. So a large clinical and health impact. I now wanted to spend a little bit of time just talking about what resources we have, where we come from at the D&I Launchpad. So gave a little bit of a high-level overview of what D&I science is. Now just a little bit about us. So we come from the Institute for Clinical and Translational Research. I'm hoping many of you, and I know many of you, have worked with us and come to some of our events and consulted with us. It was established in 2007, so we've been on campus for about 20 years, and really the goals are to help researchers grow their careers to increase impact. There are lots of resources available at ICTR. The vast majority of them are free to use, so I encourage you to look at the website to see there's opportunities around training, connecting with different resources such as protocol development or biostatisticians, as well as our D&I Launchpad. And we're really hoping to shorten the time between discovery and impact. The Dissemination and Implementation Launchpad has been a core part of ICTR for over 15 years at this point. It was one of the first implementation science cores as part of the clinical and translational, the CTSA program. And at its core, the D&I Launchpad aims to launch proven health-related innovations from research to clinical and community practice in Wisconsin and beyond. So we use scientific principles that I described earlier from different social sciences, principles of user-centered design, intervention design, organizational research to increase innovation system fit, with the goals of applying evidence, expanding reach, and accelerating adoption. We are led by our director, Dr. Shellie Ellis, as well as several staff members. Anne Gravel Sullivan is our associate director. I'm our lead research scientist, and we have a research administrative coordinator who helps us with our work. We also have a wonderful team that makes up our D&I Launchpad Academic Advisory Committee. These are folks around campus who incorporate D&I into their research and are committed to the scientific and educational missions of ICTR and the D&I Launchpad. Again, a little call out to your colleague who I see on this call, Dr. Andy Quanbeck, who has served on our AAC and provides invaluable expertise and feedback as we continue to build our team and further its mission. The D&I Launchpad accelerates adoption by providing support to investigators, trainees, and dissemination networks throughout UW and across the state. So investigators, what are the services? We do so many things, and I'm trying to explain my job and what we do kind of falls into these buckets. So investigators, learners, researchers, really anyone who's interested can sign up for free consultations with a D&I scientist. We can talk about your research and how you can integrate D&I into it. We can give an intro to what is D&I science. Really across the gamut, we can help you kind of integrate D&I into your work or just get you kind of situated in the D&I landscape. We also provide lots of local and national trainings, such as a monthly seminar, our annual short course, and kind of ad hoc trainings to support different learners. So things such as what we're doing today, but can also be more specific to any group that you might be interested in. ICTR also has dedicated funds to support pilot projects and other funds that can ignite collaborations and extend reach. So always look out for different RFAs that are being put out by ICTR. The Launchpad provides scientists to support select high priority projects. So you may have seen in one of the examples, I worked on the opioid BPA with several of the colleagues here because it was considered this really high priority project, and integrating a D&I scientist into it helped to accelerate the impact. And so also open and always interested in learning more about other projects that are happening and whether or not we can be a resource in that as well. Furthermore, we collate the best science on how to optimize dissemination networks so that they can become implementation laboratories and really support our systems and scientific network. We offer tools and resources to expand reach. And also, we just provide a home for investigators who really are interested in D&I science. And we try to connect folks across campus who are doing this work and be a home for collaboration, community, and networking. We have had over 400 investigators and 200 projects supported since 2020, and over 2,000 workshop attendees and 240 consults since then as well. Opportunity I want to call everyone's attention to include our implementation science seminar series. So we have an incredible lineup of folks who come and give a talk on the second Friday of each month at noon. You should come this Friday to hear from Ramsey Saloom and Andrew Quanbeck about the economics of adaptations and implementation research. And once I'm done giving this little part, I'll put the link into chat so you all can register for that and get it on your calendar. We have our short course, which I direct, and it is a training that highlights work pioneered at UW and also external network experts. Our next short course will be happening this fall. It will be exploring the intersection of implementation science and human factors engineering. And then we're at the early stages of planning a short course for Fall of 2027, focused on advanced clinical trials methodology to evaluate and optimize implementation strategies. So just again, showing our impact, we have worked with over 400 investigators since 2020, with over $8 million awarded to these researchers who have consulted with us in the past 2.5 years. We've worked with over 200 projects. We've had quite the reach, and folks always are coming back saying that the impact was really worth it, and that we're always so happy to work with such incredibly smart and excited people who are doing such important work. So really hope that you all can come join us and learn more about what we do, and that we can help you extend your reach and impact. We're also kind of in a new era, as mentioned several times. Dr. Shellie Ellis is new to our team. And so one of the things we did was a landscape survey. We heard from 229 participants all over campus. And what we've been hearing and learning about are what the needs are at UW now, as the kind of landscape of D&I has been changing. And we're working these results into our new direction. So really building out new implementation research opportunities, figuring out how we can extend D&I science. So things about how we can apply implementation science to support and approach bottlenecks in research, and then thinking about how we can collaborate with new UW centers and institutes. So if you want to learn more, you can visit our website for more information. Again, I'll put this all in the link in chat, and also you can email us to get more information and connect with us. So thank you all for your time. I will now switch over to Dr. Ellis to kind of give a little bit more detail about the D&I application.
Thank you so much, Felice, and really am excited to be here and to meet all of you colleagues in family and community medicine. I have worked throughout my career periodically working with family medicine. It's always been a great collaboration. And so we really appreciate Dr. Quan Beck connecting us, and Dr. and Serena for helping get us integrated into this Grand Rounds opportunity. So I mostly work in the cancer care delivery space, thinking about how to get evidence-based practice, mostly around treatment for cancer into community settings, and particularly rural settings, as well as unusual cancer care delivery settings like urological practice. But I'm going to talk today about a couple of projects, because I also get involved as a team scientist in multiple projects, and some of those are more directly relevant to family medicine. And two areas that I work in have been hypertension control in family practice settings, as well as clinical trial access. And so I think many people here might be interested in those two subject areas, so I'll touch on those. And I just want to acknowledge the funders, and I'm not going to talk in depth about any of these studies, but I will mention several of them as we go. So next slide, please. So as I'm talking about, and Felice mentioned that D&I science is a really big umbrella, and there are a couple of different approaches that people take when they think about implementation science and extending evidence-based practice in clinical settings. And one area is an approach where we try to make the clinical trials that we do more generalizable to real-world settings. And so in D&I parlance, we talk about hybrid implementation effectiveness designs. And so I'll talk a little bit about a study I was involved in that took this approach. And then I'm going to talk about another set of studies that took a more traditional D&I approach. All of these kinds of approaches, we really rely heavily on theories, models, and frameworks. And you probably hear a lot about that if you're familiar at all with implementation science. And it might seem a little bit scary, but we at the Launchpad deal with these all the time and are familiar with moving back and forth across those. And so we can always help you with that. I think it really helps ground and helps create innovative solutions to work by using these theories, models, and frameworks. And I'll talk a little bit about the ones that we've used in these studies. So first talking about the idea of hybrid implementation effectiveness designs, and I put designs in quotes because we're really not talking about a particular study design, and people get confused about that often when they're first encountering this. Really, it's this idea of implementation effectiveness designs. It's really an approach, and the idea is to think about how to fit the work that we do as implementation scientists into the model that NIH is really familiar with, which is a 3-aim clinical trial kind of setup. And so when we think about implementation effectiveness designs, we're really thinking about looking at effectiveness of an innovation or an intervention, or possibly a set of interventions. And the way you study that or demonstrate the effectiveness, you could do that in a multitude of ways with particular study designs that the biostatisticians might talk to you about. But we also, at the same time, in that same set of studies, are thinking about how we actually implement it and make sure that the interventions that we're implementing can actually be adopted or are actually adopted, and are any barriers that people experience while they're doing the trial to actually adopt and implement those things are brought to attention so we can address them as we go. And so one of the studies I was fortunate to be involved in at my previous institution at the University of Kansas was a pragmatic randomized implementation effectiveness trial dealing with uncontrolled hypertension in primary care. And this study we call VCCC, was actually, next slide, a bundle of interventions that we brought together. So there are a lot of, as Felice had mentioned, there are 11 different guidelines that talk about controlling hypertension in clinical settings. And they all say, it's a good idea, and there are a lot of evidence-based interventions that have been developed and that we know work to address these issues, but they're really not used outside of clinical trial settings where they were developed. So we took several of these things and bundled them together and eventually tested the effectiveness of this bundle. So the things that we looked at to put together into this VCCC intervention was using a population health approach. So we wanted to not wait till the patient came in to see their provider, but to look at a population level and identify all of those patients who had uncontrolled hypertension via the EHR. Then we gave them all self blood pressure monitoring devices and asked them to check their own blood pressure and monitor it themselves. The challenge with that, and I'm sure that many of you as providers appreciate that that's a lot of data and it's hard to manage that data. So we actually used trained clinical pharmacists to manage the data and manage hypertension in between the regular visits that the patients might have with their primary healthcare provider. It's overwhelming information, even for the pharmacists who are doing this, who also are seeing patients. So we employed a blood pressure dashboard that really simplified all of the data that was coming in from the home blood pressure monitors, with a simple red, yellow, green kind of system where with just a few minutes, the pharmacist could review their panel of patients that they were monitoring, identify the people that needed to be called right away, understood which patients could wait till their scheduled phone appointment, and figure out who might need some intermediate kind of consideration. We managed this whole process via phone visits. So the pharmacist, when they met with their patients regularly on the regularly scheduled visits, they would review their blood pressure readings, talk to them about adherence, monitor for potential side effects, and if necessary, make recommendations for medication adjustments. And so that could happen more quickly than the provider who would see them on their schedule, which there might be access issues to getting in. So this happened at a more frequent basis. And this was also a pragmatic trial. So The pharmacists managed the patients on behalf of the providers, and they were really following the directions of what the provider set. So if the provider had a particular goal that might be more conservative or aggressive, the pharmacist was following what the provider and reinforcing the care path that the provider had already set. So we randomized patients to this bundle of interventions and compared it to usual care. We ultimately recruited 1,000 patients into this pragmatic trial across 2 health systems, University of Kansas and University of Utah's primary care settings. Next slide. Again, in the typical hybrid implementation effectiveness kind of approach, your first aim, you're thinking about effectiveness of the intervention. It's usually a randomized trial of a primary outcome. In our particular setting, we were thinking the trial design that we used was a pragmatic trial. It ended up being completely decentralized, not on purpose, but because of COVID. We were planning for many elements of the care to take place remotely. Oh, sorry, I think we went forward, Felice. Can you go back one? Because of COVID, we ended up doing a lot of the data collection also remotely. And so it ended up being completely decentralized. But, you can choose different trial designs when you're thinking about how to assess effectiveness. Traditionally in these designs, you think about comparing other outcomes, your secondary outcomes in AIM-2. In our case, we looked at change in cognitive function, cardiovascular disease risk, adverse events, healthcare resource utilization, and mortality. And then in these kinds of type 1 hybrid trials, we think about implementation outcomes for the third aim. And in this particular trial, we did surveys of the providers in the clinics, asking them what they thought about the feasibility, acceptability, and appropriateness of these interventions. Also included healthcare administrators to make sure these are the decision makers who would be thinking about whether they're going to continue or choose this kind of intervention again. And so we asked about intention to adopt this bundle of care approach. And then throughout the study, we did a more qualitative approach to understand the barriers and facilitators that any of the providers or administrators were experiencing as we went through and tried this approach. Throughout, the qualitative and implementation outcomes were guided by the tailored implementation for chronic disease framework. And then we selected from the Proctor outcomes models, these kinds of implementation outcomes that we were concerned about. Next slide, please. So I can give you some pilot results of this study. They are just finished up the study, at least with recruitment, and are still continuing to collect outcomes of the VCCC patients and the control group. But when we did the preliminary work to assess if this whole approach were a go, you can see on the top left graph that compared to the usual care patients, the patients who were in VCCC actually used the blood pressure monitors at home and were monitoring their blood pressure, taking their blood pressure, which is a great interim step. And then after 12 weeks, the VCCC patients had a greater reduction in their blood pressure over that time period. And when we looked at what the providers thought about the different aspects of these different components of the program, what they thought about the home blood pressure monitors, having the physicians not really involved in the care process as much as they typically would be, what they thought about having pharmacists manage blood pressure, and the entire automatic referral to this program. At the start of the program, they gave it high marks. They thought it was acceptable and and that didn't really change over time when they actually experienced, hypothetically, they thought it was a good idea. And then as they experienced the program, they maintained their attitudes about the program. And so I hope at some point I can come back or invite Dr. Aditi Gupta to come and tell you more about this program if this is something that's of interest to you and addresses issues in family medicine here. So that's one approach that we use in implementation science. And yeah, you can go to the next slide, please. Another more, what we might think of as, or at least from my perspective, a more traditional implementation science approach is what I call implementation strategy mapping. And this is an approach that I use frequently in my research. And here's one example related to encouraging urological cancer patients to participate in clinical trials. And so in this study, we did a series of studies, mostly qualitative, but also then at the end, tested some of the implementation strategies in more of a quantitative design. So next slide. So in this implementation strategy mapping approach, what we typically do is first identify a practice gap. So we know that all of the NCCN guidelines recommend that cancer patients be treated in the context of clinical trials as a best approach if they're available for them, but only 8% of urological or generally cancer patients participate in clinical trials. So we wanted to understand this and what was getting in the way, particularly for urologists in community settings who were even less likely to recommend these to their patients. So we interviewed community urologists about their barriers and some of the facilitators, things that they thought were good about referring their patients to clinical trials. So we did this in Kansas, and we particularly focused on rural urology providers to get their perspectives. And we wanted to think about or design a process that would at least be acceptable for folks in rural settings and inclusive of them. Once we collected all this very rich data, you can go back one more, Felice. Once we collected all this very rich data, we did a process called implementation strategy mapping, where we really thought through those barriers and the behaviors behind the barriers that people were experiencing and map those to evidence-based practices that we knew could address the barriers directly. So we wanted to make sure that the things that we were recommending really would potentially work. And then after we do that, we're providing what we think is going to work in this setting and with good evidence to suggest it might. But it's always a good idea to then test those strategies and make sure it's addressing the problems in as many contexts as possible. And throughout this work, we relied on the theoretical domains framework, which is paired with something called the behavior change wheel, which really helps you understand which evidence-based practices might work in this setting. And then we used implementation outcomes ultimately as well. Okay, next slide. So just to highlight some of the kinds of things that these frameworks help us understand. So we're really thinking about the motivation that these healthcare providers have to do the behavior, which is referring their patients to clinical trials. We think about the opportunities they have to do that, and then about their capabilities to be able to do those behaviors. And so for these particular urologists, they actually were kind of interested and excited about offering clinical trials to their patients. They saw it as a way to differentiate their practices and have them stand out among other community urology practices. They were excited about opportunities to offer something to their patients, new therapies that they possibly didn't have at their disposal. But they also helped us understand that the way that they saw their role in referring patients to clinical trials wasn't necessarily what was happening from the trialist. So they saw their role as referring patients for consideration for clinical trials, and they really expected their patients to come back or to at least hear what was happening with their patients and potentially to co-manage their patients. And that's not really the model that's set up for how clinical trials are delivered. There was quite a lack of relationship between the people who were conducting the trials and those who had or were referring their patients. So not any trust. They didn't really know who the other folks were. They also pointed out that it was really hard to integrate trials at the point of care where they were actually useful. So they found out about the trials after they had already recommended treatment recommendations for their patients, and they needed to know about the trials and insert that into the point of care before treatment decisions were made. They also needed patients who were prepared to talk about clinical trials. They have very brief amounts of time, and so they couldn't really use their time to explain what a clinical trial was. They needed patients to already be familiar with the idea and receptive to that idea. And they also just needed to know what the trials were, basic awareness of what's available to patients, and reminder systems to help them integrate it into their care processes. Next slide. So then we did the process of implementation strategy mapping, and we took all of these barriers that people told us about, and we thought about what could actually help. So for example, I won't go through all of these, but the providers were excited about differentiating their practice. So in the materials we developed, we actually branded those and helped them tell people or market that they were offering clinical trials because they were proud of that and that was helpful for them. And so we incorporated that into the strategy that we offered. We used opinion leaders, other community urologists who they knew and were involved in their local professional societies to help propel this idea. And we created lots of feedback templates or physically developed the referral networks so that they actually had a place to call. They had problems getting through to their academic centers to refer patients to clinical trials, and we created hotlines and referral prescription pads to make those processes easier for them. And then we also provided a lot of easy support in practice. And if you'll go to the next slide, I'll show you what a few of those things look like. So to help them identify which trials were available and make them aware of them, we organized them by the kinds of cancer types that they were seeing and the stage of cancer that those trials were appropriate for, so they could see at a glance what kinds of things were available. We created these prescription pads branded with information about offering clinical trial, or telling people that they offered clinical trials there. And we created very brief patient materials to help prepare them for the conversation about clinical trials, but also about the trials themselves. So videos that could offer just the right amounts of information that both the patients and the providers needed about the trials, what treatments were being offered, and what the duration of the trial would be, and things about the logistics of the trial. Next slide. Ultimately, we were able to test this in some community practices in Louisiana and Oklahoma. And again, when we asked providers what they thought about this, these kinds of packages, they thought they were acceptable and appropriate, and this gave us hope that we could test it. So next slide. We did that, and in this pilot study, taking community urology practices that were completely naive to clinical trials, we were able to increase the number of referrals for eligibility assessment over 6 months from 0 to 30. And that yielded 9 accruals to clinical trials, which again, they had not done previously. So this is an opportunity that we would like to test at scale across lots of urology practices. And next slide. I've been able since to do some similar work in community oncology practices, particularly looking at rural practices. One of the exciting things about coming to Wisconsin is knowing the many rural practices that exist here and the rich network that already exists in Wisconsin. And so we were able to create some interventions that are directed at other parts of the process. And so, for example, this rural study design checklist targeted to the people who actually create trials to make them more rural inclusive, as an example. Next slide. Oh, you can keep going. This one's a little bit busy. So one of the activities that I'm involved in right now is actually more focused in the cancer care delivery space, but I just wanted to mention it. It's a study design that mirrors the first kind of trial opportunity that, or implementation science approach that I mentioned. It actually uses a quasi-experimental design to assess an intervention to increase appropriate targeted therapy deliver in cancer care. So one of the things that we found is that the testing, figuring out how and who to test for targeted therapy was very difficult. And we proposed an intervention called reflex testing, where we're shifting work from the oncologist to the pathology team to be more responsible for testing patients, and it's a role that's more aligned with the work that they traditionally do. So we in AIM-1 are testing the effectiveness of this toolkit that supports the change that we're asking teams to make and supports coordination and communication across different cancer teams. And we're then assessing the impact on those teams. But then at the same time, we're working to adapt this toolkit for community settings so that rural communities can also take part in this. So I want to mention that that's an ongoing study that I like to do, or I'm doing right now, and would be interested in folks who are interested in this type of work as we think about how we scale this up to Wisconsin communities, but also across the nation. So next slide. Just want to summarize and emphasize that there are numerous approaches and designs in implementation science. Theories, models, and frameworks really guide that work, and we can help you with that. But all of these approaches should accelerate the wider use of evidence-based practice, which I know everyone is here is interested in. And just to reiterate the things that Felice mentioned, the D&I Launchpad offers lots of resources and expertise to help, as well as some really great infrastructure in your department and faculty who have incredible expertise who can help as well. So thank you for the opportunity to be here. And with that, we're happy to talk about what you're implementing and how we can help and answer any questions.